3 o'clock. We'd like to start the Health and Human Services Committee meeting. Let's stand and do the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Seeing that there's no public comment, we're going to move on to item 4, the approval of the May 31st, 2023 Health and Human Services Committee meeting minutes. Motion made by Ron Cavelli, second by Donna Kraus. Any discussion? Those approve, say aye.
Aye.
Nay? Those disapproving? It stands. The agenda or the meeting minutes are approved. Going on to number 5, we'd like to do a switch from 5A with 7A, B, and C as we feel that this is out of order. Do I hear a motion to do that? Motion by Cavelli and second by Krause. Krause, sorry. Okay, now moving on to educational presentations and committee discussion. We'll do A, North Central Healthcare community programs and the treatment programs update and opportunities.
Where would you like me to go? These two, or what would you like?
Oh, you can just grab a microphone.
I can just stay here? They want everybody to
Certainly,
turn
I
their
think
neck if
so.
they didn't want to. Okay. All right, thank you. I think everybody knows who I am, but I'll introduce myself anyway. Vicki Tilka, and I'm the Managing Director of Community Programs for North Central Healthcare. So we're really thrilled to be in front of you today. I think it's been a while since we've done a detailed program update for you and just an overview of the programs that we have in behavioral health. So we'll move on right away to what are community programs, and this is really defined. Yes, you're going to run it? Yes, there you go. This is really defined by statute, and it's statute 5142, which basically is requiring counties to provide mental health and alcohol and other drug treatment. Every county has to provide that by statute, and those are called community programs. All counties are required to provide services from crisis response to inpatient care, and there's a wide gamut in between. And that's a lot of our programs that we're talking about today cover both ends of that, but then also what's in the middle for us to be able to provide good quality care for people in our counties, as well as being cost efficient so that we can avoid having inpatient hospitalizations, which are very costly. The other major statute that we work under is chapters 54 and 55, which is our adult protective services and on adults at risk, as well as guardianship and protective placements. So those are our big pieces of what we're going to talk about today. Oops, I know I was going to mess that up. Which one? Thank you. All right. So we're going to talk today about our mandated programs, and the ones that we're going to talk about are specifically for Marathon, Lincoln, and Langland. As you know, we're a tri-county organization. You might not know we're only 3 of 10 counties, and we have 72 counties in Wisconsin, so just 3 that are not operating as a human services department. So together, our programs with social services department comprise what is considered human services that are required in the statutes that the county needs to provide. So this is our desired future state, and I know you all have this laminated, probably posted somewhere prominently where you sit at your desks or your chairs, right? And so this is something our executive committee created for us prior to those of us coming into senior leadership in January, with us having this basically as a mission statement or a guiding star. And I highlighted the things that are the most salient in the desired future state, which is, again, our 3 counties working together with our social services to be able to work seamlessly to provide services to people in the community. We all provide services to the most vulnerable, and many times we're providing for the same people. And obviously the services involve our partners in our behavioral health and child welfare, youth justice, and criminal justice system is a large user of our services as well. So that is, again, our grounding vision, and everything that we're doing as we're moving forward supports this. So our core services, these are the ones that we are providing to our county partners, which are crisis response, outpatient therapy and psychiatry, community treatment, and adult protective services. And so those are only for our 3 counties. The other ones that I just called enhanced services, I kind of made up that term just to kind of show the difference, are our inpatient and crisis stabilization facilities. And it's an important distinction because while we are required to provide inpatient services or arrange for it, pay for it is really what the statute's saying, we aren't required to necessarily provide it in Marathon County. That was a choice that was made some time ago with our adult psychiatric hospital, and then more recently our youth hospital, that it was a better choice for our community as well as financially for us as well as our other justice partners to have our hospitals located centrally. And the same thing with our crisis stabilization facilities. We need to have access to those services. We don't necessarily need to provide them in Marathon County. However, we found that it's in our best interest to do so for the same reasons. And then we are going to soon be opening our Lakeside Recovery medically monitored 28-day residential. So let me go back and just say our inpatient and crisis stabilization facilities are open to other counties. We're working on a regional approach there. The one that's soon to be open with Lakeside Recovery, that is only going to be for our 3 counties because it's only a 16-bed capacity. And we think that we will be filling that up quite quickly. And then we'll see over time if what we have for demand. If we can open that to our other counties outside of our tri-counties, there's very much interest in that. So let's start with our crisis services because this is really where a lot of people will connect with us for the first time, or certainly when they're in a crisis. So that's governed under DHS 34 and Chapter 51, which really has more of the emergency detention part where it's involuntary. So again, contact with the crisis center can be voluntary or involuntary, eventually be involuntary, depending on the scope of what's happening with the person. A lot of our people are seeking that service voluntarily. And basically what it is, it's a 24-hour available assessment and support system for mental health and substance use crisis. So available 24/7 every day of the year. So very complicated to staff, as you can imagine, but this is where our crisis professionals are doing both assessments of people who walk in literally to our crisis center to ask for help, or at times we're able to deploy our crisis professionals mobily. That most often happens going to the jail and going to the hospital. And then phone assessments occur as well when there's no other choice to be able to do that. And at the end of the day, when our professionals are doing their crisis assessments, they're always looking at what is the least restrictive level of care needed to assure safety. So with many of the people who are calling for help, we're able to talk them through what that crisis is, talk with them about who other supports are in their life, and make sure they're connected to those people. Some of the people call us back for ongoing support to avoid having something else happen to them that's not in their best interest, so there can be some ongoing types of conversations, or it could be just a one-time thing. So this is really the hub of what we do, is our crisis center. It's paramount that this be staffed well. We're struggling with staffing. I'm going to mention that at the end, but this is one of the areas we're struggling with staffing in the greatest. It's a very difficult job, and again, being 24/7 in the high pressure of the job, our staffing level is getting better. And when we get to a certain point, we can look at expanding some of those and becoming more mobile, which is what we want to see. And we also have our crisis response team, which is CART, and that's been a presentation that has occurred, I think, with a number of committees, where we have 2 of our crisis professionals teamed with an officer from the Wausau Police Department and then somebody from the Sheriff's Department as well, and they go out at different times to try to address a crisis and then to avoid something else happening deeper in the system. So we're not using the criminal justice system for somebody who has mental health. This is a very well-respected and popular program that a lot of people are interested in us expanding because it does have really good results. Our challenge with that is that even right now with our 2 crisis professionals who are assigned to this, they're pulled off of CART at times because they're needed back in the crisis center because, again, what I said is our foundation has to be that our crisis center has to be adequately staffed to be able to respond to the calls and walk-ins that occur, and that's our statutory responsibility. So that is a caveat there. We also then do have 1 full-time equivalent mental health therapist that is assigned and located in the jail, who does a variety of duties for the jail population as well. And that is something that not all counties do, so I point that out as being unique for Marathon County, or at least somewhat unique. And then we have our crisis stabilization facilities. So we have our one for youth that is licensed for 8 beds, and that, of course, is age 17 and under. Voluntary, both of these are voluntary for people that feel that they need that support, and for a youth, a parent has to sign as well. And again, it's focused on mental health and substance use. For youth, we can do brief therapeutic interventions, or BTI is the acronym there, which is for youth that we can predict that a certain situation is going to cause them some challenges in their present environment and kind of plan for that, take them out of that environment periodically, and that works really well for some kids as well. So we do that in the youth crisis stabilization facility. The adult crisis stabilization is currently licensed for 8 beds, but we're transitioning to 16 beds once we can move from the current facility to a larger one that is in a different part of our campus. And that was part of the remodel. We have received a 5-year, very large regionalization grant to be able to expand the adult crisis stabilization facility to be able to take more people. We are generally quite full, up to close to our 8 beds right now. And we know that when we move, we will be moving that number up significantly because there is demand. And while we've been marketing with our other counties outside of our tri-county, because that's one of the requirements of the grant that we accepted, we haven't been as aggressive on it and really getting out there and making sure people have that access as much because we don't have the increased capacity yet. So once we do that, we will be able to really get out there and do more marketing of it, which helps our census and helps the money that we're able to apply to our services as well. It can be used for a step down after the hospital, and that's done often for people in both youth and adult, as well as we can have a level of detox on the unit, but a certain level only because we are not a medical hospital. So people do have to have medical clearance and be at a certain level in order to be admitted to the hospital if they are actively using. And then I mentioned the regional grant expansion. You know, one example I like to use because it was like a real point in time and something that I did not know this as my affiliation with the county for so many years is a use of the adult crisis stabilization facility came in when I was actually here at the courthouse visiting our justice coordinator, Laura Yeri, and they had just had drug court, and she had said, well, we have somebody that is wanting to have some stabilization. She's not using currently. She wants to not be with people that she normally associates with because she's very fragile in terms of her treatment, and so she wants to have a different setting. And is adult crisis stabilization appropriate for her? And I said, I believe so. This was like in January when I first started, but I said, I believe so, and let's call back there and see. Well, she had been turned down before because when she had come in, she had asked for detox. And our adult crisis stabilization facility doesn't do detox. So she asked for the wrong thing, thinking they thought she was actually using when we figured out what was really happening. Now we're being really clear with everybody that that is an appropriate use of the stabilization facility as well, to give people some time to be able to stabilize and feel stronger before they go back to a home environment. So lots of really important uses for it. And then we'll move on to our inpatient hospitals that, again, are 24/7 care. These are locked units. The other ones are not because they're voluntary. And so this is 8 beds, ages 13 to 17. And again, with mental health, substance use, requiring inpatient care by a psychiatrist. And of course, there has to be a diagnosis and insurance accepted for those stays as well. Just to give you some numbers, in 2022, 295 youth were served, and through June of 2023, it's been 155 youth. And then at the Adult Behavioral Hospital, 16 beds, and again, voluntary and involuntary, because people can be detained and placed there as well, and a level of detox, but mostly it's psychiatric care. Medical clearance is required. In 2022, we had 686 adults, and through 623, it was 299. So our census has fallen a little bit in the adult if you look at it as a straight line. So we'll see as the year goes on where we end up. We have a number of plans in place to increase our census, and I'll just touch on that at the end. So the numbers served in crisis, and this would be people connecting with our crisis center, crisis call center, or the in-person that I talked about, through June of 2023 is 1,647, which is a really high number, I think, and I think a lot of people don't realize how much use our crisis center actually has. And then the youth crisis stabilization stays in 2022 were 169 stays. Those are not necessarily 169 different youth. Some youth come more than once. Some of it's planned, as I talked about. And then the first quarter of 2023 was 84. In the adult crisis stabilization, 2022, it was 272 stays. In the first quarter of 2023, it was 71. So on target really there for being a similar year, likely. So the youth crisis stabilization does look higher in this first quarter because we opened it up to day treatment when we were not able to hire overnight staff, and so we were able to take some people in that regard, but that's really not the point of the youth crisis stabilization facility, and we have received a grant for us to provide 24-hour care for that, so that's not the model that we would be pursuing, but we were able to, I guess, make lemonade from lemons when we didn't have the overnight staff. We were at least able to open it during the day, and some of our partners really appreciated that. And we have that periodically now, even in the summertime. So outpatient services, that's a whole nother area that we have. So our hospital and our crisis center, as well as crisis stabilization, will often connect people to outpatient as a source of support to them as they continue on with their treatment plan. So it's really beneficial that we have this as robust as we do as well as on our campus. And we have this in all 3 counties, outpatient services, mental health therapy and substance use disorder. We have individual and group counseling available. And then, of course, we have psychiatry, which includes medication management and nursing support. And then we have the intoxicated driving program, which is required of counties to be able to have. And then also you may be aware that North Central Healthcare is a big user of our resident psychiatry program through the medical college. And we do receive a number of residents every year. I think we're getting 9 coming up that are then stationed at either participating in outpatient, even in our crisis center, which is something very unique that we can offer as an experience, as well as the hospital. So they get a really well-rounded education depending on what year they are in their schooling. So that's really important to us because it provides support for us for service delivery, as well as potentially an ability to recruit some of those people to work with us when they graduate. Here's individuals served in outpatient in 2022, broken down by county. So you can see in outpatient mental health, 495 in the Wausau campus, which would be primarily Marathon County people, but there will be some from Langley or Lincoln County that drove here as well. We did not break that out, but the majority of those will be for Marathon County residents. And then outpatient psychiatry, 1,533 individuals served. And then for substance use, 764 in therapy for substance use. So a pretty significant number. And you can see the corresponding numbers for Antigo and Merrill as well. Okay, and then our other big area is community treatment. And so this is basically our case managers and we have nurses in this program as well, who go out into the community to see people who have substance use disorders as well as mental health who are voluntarily wanting to receive support for treatment, recovery, and be as independent as possible. So that's really the goal of the program, is to support people as they recover. Community-based, again, they meet people in their homes. If they don't have a home, they'll meet them where they are staying. They come to our office. They drop in at our office. They see people in the community a lot. They can administer people's medications, and some of them are on commitments where they're required to take a medication, and an injection is usually the best choice because that lasts a long time, and they will deliver that injection wherever they can find people and wherever they can agree to have people take their medication. So this program is for both youth and adults, and when we look at the adults, we also have a team that specializes particularly in our higher needs adult, of people that are needing probably daily check-ins, and they are able to do that. And that one is pretty much through the community support program. I listed all the C's. We always say these are our C programs. I mean, look at all these that all have to do, they're different levels of case management for either adults or children, depending on what diagnoses are, and what's also included as service with the case management. So that's kind of the difference between all those. And I could explain those all to you in detail if anybody's interested, but kind of rolled up, that's what that all does. It's our community treatment programs where our services are delivered directly in the community for people who qualify. As I said, it's a voluntary program, so people have to sign a service plan saying, I want this. I want you to help me, and this is what my goals are. And I always put a caveat on that. Because recovery is kind of an up and down situation. The next day they might tell us we're not welcome, but that doesn't mean we actually go away forever. We'll come back again and try, and keep trying to engage people as we can. So this, the people who are served in this have a greater need than outpatient, just to let you know kind of the acuity. And often they will have outpatient as well, but it's really their case manager that they see through this that I think they rely on a lot. And a number of these people are also in our criminal justice system as well. The next slide has how many people are served in community treatment in 2022. And again, it's a pretty large number, 858. In Marathon County, 285 adults. And Marathon Youth is 265, so almost the same. And you can see the little asterisks there. So we do contract with social services so that they can do service facilitation for comprehensive community services as well. And they have 90 of the youth out of that 265 are ones that they provided case management to in 2022. And North Central Healthcare was 179. So we don't provide case management to the same youth. They're separate, and it assists us in being able to serve the whole community, and it assists them with their presentation. They're going to talk about it in a little bit on why this program is helpful for them to have as well. So we as a team serve the youth together, but the adults are served only by North Central Healthcare. And then our other area is adult protective services, and once again, this is required by statute for a county to provide this. Primarily as adult at-risk investigations for those people who are either age 60 or older, or have a physical or mental condition that impairs them from their ability to care for themselves. And so again, it could be abuse of any type, neglect, and financial exploitation, which is a significant report that we get. And really what our obligation is and what our role is that we are looking to help people with what a long-term care plan would be. And for people who are incompetent, then we need to step in and provide them supports in the form of potentially a protective placement or services and guardianship. Guardianship is, of person and estate, and we always look for what's the least restrictive, help families with a safety plan, help them to provide, if they can do a healthcare power of attorney, for example, or something like that, rather than going to a guardianship, and then you just kind of go up the ladder in terms of more restrictive all the way to a protective placement, which is really the most restrictive that you can be, in which people have a lot less choices about where they can live and things like that. In 2022, we completed 683 investigations, which is a lot for our 3 counties, and 55 new protective placements were completed as well. Okay, and then here's our Lakeside Recovery, which is a medically monitored treatment unit, 28 days, 28 day program for 16 beds. It is voluntary, so people can walk out of the unit. Always be clear about that. It's unlocked. The license is pending with the Department of Health Services, and I was hoping it was going to be soon, and it looks like it's going to be delayed even further. So I will perhaps be reaching out if there's any advocacy that can happen, as we have our license certification with the Department of Health Services. So we are ready to open as soon as we get certified. So that's exciting, but yet a delay. And then we have our sober living programs, which are really important to our partners in community. This is something that people have identified to me that they hope that we never close. We do have some financial challenges meeting our budget with these. In Wausau as well as Antigo, Langley County has provided some money towards that to try to make our budget be balanced. The Wausau home focuses specifically on adult males, and the Antigo home focuses on females. And we can have people from other counties go to each of the homes. It started out with Langley County wanting to keep it exclusively for females, but they really were not able to get up to the census, so now any of the counties can go. But we're still struggling in Antigo. There aren't enough females who are interested, available, ready to go into that setting. The male home in Wausau tends to be more full. The model is basically staffed by a lived experience house manager, so it's somebody who's lived there, done very well in the program, and is now going to operate as the house manager, and then they don't have to pay rent. It's in exchange for being rent, they're there as a support person for the people who live there. The people who live there do have to pay rent after a certain period of time, and they have to have a recovery plan in place and seek treatment and be working and trying to find a job and things like that. But we do not provide treatment in the home. It is not licensed as a treatment facility. However, people have to be sober to be in this home. So those are the different caveats. But again, seeing success with this program, and again, it's valued by our partners. So on to our challenges. I put staffing, like location, right? But staffing is number one, and I know you hear that everywhere, but I will tell you in 24/7 programs, it is even more so difficult. People don't tend to want to work the night shift. And even a few years ago, they were more willing to do that because there would be like a little bit of a cost stipend, and that made a difference. And now in the market that we have, it doesn't make much of a difference anymore. So we're really struggling with that, specifically in nursing, and then our behavioral health professionals, which are kind of like our mental health techs that are on the unit. Those are the two areas that we are working on a very pointed recruiting plan to try to improve that. And then our crisis call center, as I already mentioned, is the other one that is at an extreme critical staffing. Both of these would be critical. I would say, our staffing in general is a challenge like it is everywhere, but these are our most critical areas. So in order for us to build our foundation, to be able to expand to what we know our partners are interested in having us do, we've got to get a hold on this. And the other piece of it is the safety and security on campus, because we deal with we treat a number of people who have extreme behavioral issues, and at times, can present very unsafe for themselves and others. And making sure that we have staff that's adequately trained, as well as our physical environment, which when we're doing the remodel and just relocating units, everything has to be redone. The cameras, the locks on the doors, et cetera, and to make sure all those things are in place as we're moving forward has been a challenge. But we're getting there, but we need to do better on the training in particular. The other thing, I just say this wherever anyone will listen to me, is for people to give us patience on what we're doing. Our leadership team that has been put in place in January, Gary can talk about this for a moment if he wishes to, but we know what we've been asked to do in terms of working with the counties in a different way, and we have a plan to do that, and we've made a lot of progress actually, but we need more time to actually strengthen our foundation based on what I just shared with you. And the kind of famous saying that we always say is, to be effective, we must be selective, right? I think in the past, North Central Healthcare has said yes to a lot of things under pressure from partners, and I will say I was one of those partners that gave pressure, and they didn't have the capacity to do it, and so many times it didn't work. And we are committing that we're not going to do that. We're going to do this strategically, and we will be able to be successful in expanding in what people need. So I think that was my last slide. Oh, I'm sorry, no, it isn't. So we did want to shout out some successes because we do have overall in the last few years decreased use of Winnebago as an inpatient hospital, which saves money, but it also is less time for law enforcement to travel. So if you would talk to the sheriff, he will tell you he has no complaints about that. He's very happy, and other sheriff's office who have to do transports across the state, he's talked to them about, well, just drive as far as Wausau then and get your people in our hospital because it makes a huge difference. And, you know, Winnebago being a state hospital, they are very full with patients. And so I think their care, sometimes they're discharging people perhaps earlier than what professionals would like to have. So we would like to say that we would have a better quality of care in our hospital as well. We've been admitting more complex patients over time, and that really, I say individuals because it's patients in our hospital, but it's even when you think about who we serve in community treatment, we're serving some individuals that you know, can bring us some pretty complex behaviors. And then we are increasing the number of counties that are using our facilities, so that helps us with our overall financial viability, so we can still provide those services for our 3 counties, but be able to do it in more an affordable manner. And then as I talked about, as we're building our foundation, the opportunities that we want to have is new or enhanced programs on the campus to meet our desired future state. We have a couple of physical opportunities on our campus, so we have some ideas in mind, and we're listening to partners as we go around in our different committees and task force and things like that, and some ideas of what that could possibly look like. And then as I talked, we want to expand our crisis services because that's so important. And the better job we do up front in responding to crises, the better we're going to have all the way along the continuum and have less people be hospitalized. So that's what our vision is. I really do think that's it. Just my name and my information. So Gary, I don't know if you wanted to share anything. Oh,
Yeah, I'm after this, but do you want to share something?
Now, or?
Yeah, I'll just touch on one thing just really quick. Vicki alluded to this, but the 3 of us, Jason, who will address you in a second, who handles the finance, Vicki and myself, we're new in our positions as of January. But when you look at the one thing I think that was lost, because all of us are county. We came from county. So Vicki from Marathon County for many years, Jason from Portage County and Lincoln, and then he was at Marathon for a while, and myself between Shawano and Langlade counties. So the thing that I think gets lost a lot is that North Central Healthcare is county. We exist because of you. We're an arm of Marathon, Lincoln, and Langlade County. That's what we are. And I think now, for the first time in the 16 years I dealt with North Central Healthcare at Langlade County, we finally have that vision. And you've seen the future state that was shared with you. And we are working with that vision and getting that across. The Human Services Committee that was established by the Executive Committee that has Krista on there, has each of the 3 counties directors of social services, you know, the human service aspect, the other side that serves with us. It puts us in better contact with the counties and what we need to do. And I think the key part of what Vicki said, having patience with us, because I found out that North Central Healthcare is a very large ship. And to get a ship that size turned, it doesn't turn on a dime. And we're in the process of doing it. We realize that there's a few barriers that we're getting through, and the communication is a huge one, that we're getting that communication fixed. And there's a lot more that we have to do, but we're in the process of working on it. And I think that that's the important part, is that we realize that we are county. We exist because of you, and we're here to serve, you know, the underprivileged individuals that we need to serve, to do the programs, as Vicki detailed very well in here, that you're required to have. So I appreciate the time to get in front of you to say this, and I'm hoping that we get more opportunities to come to share where we're at, because I'm excited for the future as we move forward and get things in place. And I'm grateful for these two because having them with the same mindset keeps that ship going in the right direction. So we're moving it, and it's heading there. So.
Thank you. So as Gary said, my name is Jason Hake. I'm the Managing Director of Finance and Administration, and I've been here about 6 months prior to joining North Central. I was at Aspirus as a Director of Finance for 2 years, and then I was in county government for about 9 years before that. And I worked in finance and administration. So I do understand county budgets, and in my opinion, the community programs budget in county government is the most complex budget with all the different funding sources. In North Central, the size of it and splitting it between 3 counties just makes it that much more complex. So we do have a very complex budget and financials within North Central. So if we look at the charts that I have up here, I apologize, they're kind of small on the screen, but if we look at the left one, the 2023 revenue, these are numbers based on our 2023 budget. You can see our total revenue in community programs is just over $34 million. We have that broke out into 3 different categories. We have net patient services revenue, which is it's $21.7 million. We have our other revenue, which is just shy of $8.8 million, and then our county appropriation, or which would be our tax levy, of $3.6 million. And I'll get into the details of what those are. Just wanted to give a high-level overview of, the sheer size of community programs within our organization. If we look at our 2023 expenses, our total direct expenses are $31.6 million. So like county government, salaries and benefits make up a large portion of our expenditures. It's about 72% of our expenses in community programs are salary and benefits. And that's just because we are service oriented. We provide services to the community, all the services that Vicki just talked about. So that is where the majority of our expenses lie. We do have about $8.7 million in other direct expenses, and a lot of that are contracts that we have with providers to provide services in the community that maybe we do not provide. So if you look, I do want to point out, if you look up here, we have, it looks like our revenue is much higher than our expenses. And that is because this is our direct expenses. So we are not making money. I wish we were, but that's just not the case. We are not a revenue or a money-making business. What we do is we are covering our indirect expenses. So year to date, we are right around break even if you include our indirect expenses to provide our community programs, which is great that we're covering our indirect expenses, but we're never going to generate a profit by providing these services. We're providing services to the most vulnerable population in the community, and our largest funding source is Medicaid, which is usually the lowest payer. So I did just want to point that out. Yep, you can go on. All right, so I'll touch on the revenue piece. So if you remember, net patient service revenues, $21.7 million. So what that is made up of is when we are billing for services that we're providing. So that includes Medicaid, Medicare, commercial insurance, and then it could provide other services like the CCS service or comprehensive community services, our community support program, CSP, I forgot to include the other one up here, CLTS, and then private pay. So a lot of those, Vicki mentioned the C programs, community programs, I like to call it, it's the department with this, all the C programs. Everything seems to start with the C here. So why this is so complex at our organization is within some of the programs, we have multiple funding sources. So in community treatment, Vicki mentioned there's CCS, CSP, CLTS, along with different grants. So we need to break out all of our revenue into different pots of money with our expenses following those revenues. And it sounds easy, but I can tell you that it's very difficult and very complex. And then on top of that, we have to split that between 3 different counties. So that's what really makes this budget very complex, is all the different funding sources. If you look down below, we have our other revenue. That's the majority of that is grant revenue. So within our programs, we could have, for example, a social worker or service facilitator providing CCS services, CLTS services, CST services, which is a grant, and we need to split out all of their time and expenses between the 3 programs or more. There could be more, along with indirect expenses, all with the majority of our expenses being payroll and benefits. So it sounds like it should be easy, but it really isn't. There's no good, way of doing that. And I know social services has to do similar things that we do with their CCS and CLTS and grants, and I think they could attest to how complex and time-consuming it is. So the last thing we have is our county appropriation for revenue, and that's just our tax levy. So we can go on to the next one. All right, so expense overview, like I said, we have our salary and benefits. That makes up the majority of our expenditures. We have in community programs 243.29 budgeted FTEs in 2023. So as I said, we need to break out their expenditures between all those different funding sources. We have to do that for all 243 FTEs, which is very complex when we have billing software and time management, timekeeping, payroll software that don't talk. And that is not unique to North Central. I think social services probably has the same challenges that we do. We're a very complex organization, so finding something that could do that just doesn't exist. So that just adds that level of complexity to our financials. And then on top of that, let's not forget, we have to break that out between 3 different counties, where you could have employees working in multiple counties at the same time. As I mentioned, our other direct expenses, a lot of that are contracted services. So, for example, we in our CCS, or Comprehensive Community Services, we contract with a lot of providers to provide services for us. So that could be therapy, medication management, individual skill development, whatever falls within the service array of that program. So a lot of our expenses are related to that program and us contracting with providers within the community. This does include our out-of-county placements. So Vicki mentioned Winnebago costs and how that's decreased. Those would fall in here. And then just other operating expenses. So program expenses that we have, vehicle or mileage expenses that we have, because we provide a lot of services in the community. We do travel quite a bit in some of our programs. And then we have drugs for our individuals is another expense that falls within here as well. So that is a very high level overview. I just wanted to kind of share what the size is of community programs and kind of touch on the complexity of it. So I really enjoy doing this stuff on the finance side and learning about the programs and services. So if anyone would like to spend more time, I would be willing to sit down with anyone and go over this in any level of detail that you would like. So I could bore you for hours. So are there any questions?
Thank you, Donna.
Yes, thank you. I have a question. In the other direct expenses, you have drugs. Is that something that the insurance pays for, or the county is supposed to pay for, or why is that an expense there?
Yep. So in some of our programs, it would be a reimbursable expense that we are billing insurance for. Some of that, if you look on like for our inpatient units, we're providing drugs, but that drug expense is built into our daily rate that we bill. So, for example, we bill in our adult inpatient unit $2,000 a day, but that would include room and board, staffing, drugs, all of the expenses associated with that stay would fall in there, but we still have to purchase those drugs to provide to those patients. So it is, yes, they are reimbursed.
Another question. I don't know if this would relate to you or to your medical staff or whatever, but I know two individuals. I don't know a lot of people with schizophrenia, but I personally know these two individuals, and they're given medications like 5, 6, 7 different kinds of psychiatric drugs for schizophrenia, and I can tell you it doesn't help at all. One is under commitment, and so somebody's coming to her door to make sure she administers. She takes it, they watch her swallow it and everything, check her mouth to make sure she hasn't hid it under her tongue or in her mouth somewhere. The other one, I don't believe, is where somebody comes to the door to give him his meds. It's possible, but I've never inquired. But I have personally seen them go way off, mentally, hallucinating, talking to themselves or other people that aren't there. And I'm just wondering, what is ethically and financially, what would be, is it a good idea to load them up with these drugs when they're not working for that individual? They're not helping that individual, because that's an expense, and I'm sure those drugs are not cheap, especially I don't think lithium is cheap at all. But I was just wondering about that, because these people are forced to take it and it doesn't help.
Well, I'm only going to speak in general, of course, and I'm not a clinician, so I always put that caveat out there. But I have learned a lot from clinicians in the time that I've been there. What I would say is schizophrenia in itself is a very, very complex diagnosis, and it is a long-term diagnosis that there really is no cure for, so to speak. And all we can do is address some of their symptoms through medication. So sometimes it might even appear that medication is not making an impact when really it is, because they're still going to appear to someone else as having some issues. So again, very complex and very treatment adverse. Is that the correct way to say it? Hard to treat. It really is. It's a tough one. And so people who are experiencing symptoms that go along with schizophrenia can have a lot of emotional pain. So even if they're not working, to your point, a psychiatrist is going to look at how do they give them an ability to be as stable as possible as they can inside themselves, regardless of what their goal is for the day. So just very complex is what I would say to you, and difficult to kind of look at somebody at a point in time and make conclusions about what their treatment plan is.
I'm aware of that, but can somebody go to their psychiatrist and tell them that, because I employ one of them, and say something to the psychiatrist that maybe their medication needs to be revised, or ask that particular individual, tell them that it's not working? That can they go and speak to their psychiatrist about it?
Absolutely. Psychiatry, they're monitoring the medication. So absolutely, people should be telling their psychiatrist how the medication is making them feel. Their symptoms are going to be asked about that in every visit, and the psychiatrist will be evaluating that. That happens on a routine basis. Otherwise, the medication can't be prescribed.
Any other questions?
Thank you, Madam Chair.
The Supervisor Moore.
Does she have a question also?
Sorry, go ahead, Supervisor Cabelli. This is Supervisor Morash. I have a question when it's appropriate. Thank you.
Okay, thank you, Supervisor Morash. So, Vicki, thank you and your team for the presentation. Knowing me, the data guy that I am, I like to see the data, which is great. So part of our goals and objectives on this committee are trying to figure out how we can help reduce some of the issues that are going on in the community, mental health, suicide, drug prevention, that kind of thing. And we have it in our goals and objectives, and we talk about it every year. So, you know, the data that you brought today treats the symptoms, right? So what I'd like to see maybe in the near future for us to help, you know, come up with our objectives and our goals is what can we do to help reduce the root cause of the problem, right? Because, you know, you can add extra beds, you can add extra staff, but really in the community, what is really going on that is causing us to add more beds or add more staff, right? And you don't have to answer that now, but it's something to think about, you know, as a team. Maybe we can, you know, do some troubleshooting together and try to figure out what the root cause is and how do we, you know, eliminate the root cause, right? So, thank you.
Supervisor Marash.
Thank you, Madam Chair. First of all, I want to say thank you to everyone for your presentation and your hard work taking on this endeavor of turning the ship around. I have several questions, and just because I'm very curious about a lot of things. So you listed psychiatry, and I'm wondering what is the current wait list, do you know, for when a person is diagnosed as needing psychiatry? How long does it take to actually see a psychiatrist?
I really don't have specific information about either therapy or psychiatry in general, but what I will say to you is we do have open access hours that are for psychiatry that is run by our resident. So I believe that is a pretty quick initial screening with a resident to be able to get introduced to psychiatry. We actually have more capacity right now in psychiatry than we do in therapy, which is kind of a reverse situation than we might have had in the past. But I didn't come with specific numbers in terms of how quickly we can get somebody in for a first appointment. So I apologize for that. And it does change over time pretty quickly, so it's hard to answer that question. The answer could be different next month.
Mm-hmm. I understand. Okay. And then mentioning that taking on some patients from other counties, which other counties are we seeing people needing services from? And then what does it look like in regards for reimbursement? Do they pay out of county, you know, like a higher amount because they're out of county?
So we have a contract with a number of counties, and of course, we're serving the 3 counties as part of our ongoing response. But we have contracts with other counties, and I don't have the name, how many we have or the names of them, but we are really trying to increase that. So I would say there's at least 15 counties we have an active contract with, and they would pay the full cost of care. So the counties are signing a contract saying that they will commit to paying whatever insurance doesn't pay. However, because we have experience, basically insurance or MA, depending on what the person has, pays for the cost of care. So we don't really, they're not paying more, but they're paying their full cost. Did you have anything else you wanted to add to that? Okay.
Did you have any more questions, Supervisor Marash?
Yes, I do. Thank you. So you mentioned that you're hoping for Lakeside Recovery to be opening in the near future. Do you have any idea of when that will be?
Unfortunately, no. I'm learning that in working with the Department of Health Services that we have to be very cautious about what information we share from them. From each surveyor seems to have a little bit of a different perspective on timing. So I'm not going to project anymore. I've learned that a hard lesson this last week even. So I really don't. What I can tell you is that the physical unit is ready and we have the staffing, which is significant. So that's that last barrier.
Right. Well, that's good news. And then also, when you said that your staffing is in a critical stage, can you explain that a little bit more? What does critical mean?
Well, in the crisis center in particular, we have a 40% vacancy rate. and in our nursing profession and behavioral health professionals. I don't have a vacancy rate for you. What I can tell you is that we have so many open shifts for the last 4 months that we've encouraged our employees in taking up extra shifts by paying them double pickup pay so that they can take on more hours, and that's the only way that we're able to continue the programs as they are. But I don't have numbers of positions there. But our ads are constant, and we're changing them up to try to be more attractive, to get more people. And we do. I mean, every one of our new employee orientation groups are larger than they have been even 6 months ago. So we're making progress there. But I don't have the number for you in the 24/7 programs.
Right. Yes, I understand, and I completely appreciate the difficulty in finding staff as everyone is facing those same challenges. I guess my last question is, and I know you won't have the answer, but even if you could email me later with it, possibly, like if you had a level of the various programs that you're offering and what level they're currently operating. Like you said, the crisis center, you're suffering with staffing shortages. So, I mean, are you able to be open 24 hours a day, 7 days a week, or are those hours, shortened right now in the youth behavior hospital, et cetera? So you don't have to answer that now, but if it's possible to get me that later, I would appreciate it.
No, I can answer that right now. Our crisis center will never not be open, and that's why I'm saying that is our number one priority. So we would pull people off of, again, our cart. They have to be trained crisis professionals, which is they're their own unit, but that is always going to be open. Our hospital, our adult hospital, is always open. A worst case scenario is we may have to not be able to accept an admission if we don't have adequate staff. Where we have had some closures, particularly this summer, has been in the youth behavioral hospital and youth crisis, and that is for 2 reasons. And it's short term. One was like a 5 or 6 day closure, and one was a 2-day closure for the youth behavioral hospital, and that's for 2 reasons. Sometimes we don't have any census. Literally, there aren't children who are youth who are admitted, and so it doesn't make sense for us to be able to keep a staff open. In the summer, in particular, we have less referrals overall for our youth services, very similar to social services when school's not in session and there aren't people to necessarily report or request services. But then the other piece is there aren't as many demands on youth in the summertime, and so sometimes their behaviors don't escalate to the point where families are asking for assistance. So that's typical across the country, is that youth behavioral hospitals and youth crisis are not as used as much during the summer. So that's the answer for the youth behavioral hospital. We evaluate that based both on staffing and census. And again, it happens during the summer that we have temporary closings, but they're only temporary. And again, if we know we're going to have low staffing, we're not going to admit a youth and then have to discharge them a day later if we can predict we wouldn't have additional staffing. So there's a kind of an art to being able to evaluate that. And then the youth crisis stabilization facility really depends on having overnight staff. We've struggled with that, and we really need to figure something different out. We have one theory is that we have downsized our requirements in order to get staff. We used to require people to have a bachelor's degree, and now we don't. And so while that allows us to hire more people, we're finding that's a challenge for people sometimes to be able to provide that service. So if we would increase our credentialing for that, that would increase our cost as well. So those are all the things that we're looking at doing and trying to keep that open.
Okay, thank you very much.
Donna.
Thank you, Chair. I was wondering, I received the newsletter for North Central Healthcare, and I've seen the job position for crisis professional in there for at least a month, and it's the night position, and I noticed that it also said that they must be available to work, I think it was every other weekend, and I was thinking that's a really high-stress job, and to have them work additionally on every other weekend must be quite a strain on them. And I was wondering if the job descriptions in that could be changed so that you have so that they wouldn't have to be working every other weekend or every other holiday too, in addition to working full-time.
Well, the challenge with that is people have to work on the weekend because these are 24/7 programs every day. So that is part of the nature of the job. So if people aren't willing to do that, then that could certainly be a reason why we struggle with staffing. But unfortunately, that is what's required.
Thank you. Any other questions?
Oh,
Yep. I just wanted to expand on the expense piece. Something I forgot to mention is our indirect costs and what makes up that indirect piece. So within our organization, our indirect costs would include, just like the county's indirect costs, our HR time, administration time, IT time, those services that we then spread out within our organization. I think the difference that you see if you look at our financial statements compared to like a county program like social services is we do an internal allocation each month. So our indirect expenses are hitting our financials each month, where the county will do, it's called an indirect cost allocation plan. So they have that number, like social services would have the number of how much time is administration or HR or IT or corp counsel spending on social services, so they can draw down those funds. Ours just happens to be, directly applied in our financial statements to our programs. So that it's a little bit different than county government, but that's what we need to do for our cost reconciliations that we have, our rate settings that we have to make sure that we are maximizing those expenses. So I just wanted to clarify that because that first slide I did mention indirect, but I wanted to touch on what do those indirect costs make up. So
Thank you. Any other questions? Well, thank you, Vicki, Gary, and Jason for all your work on this. Very detailed, and we appreciate it. Moving on to 7B, United Way 211, update on service provision.
All right, Madam Chair, and we have Megan from United Way here to give us a presentation. So if you can bear with me, I'll try to find it in the packet. And one other thing, just to close out your last presentation, if anyone's looking for a report that is an interesting read on staffing and the challenges of staffing, the Wisconsin Policy Forum just issued a paper relatively recently talking about the largest kind of bottleneck in the state of Wisconsin relative to positions, and they highlighted 3 categories of positions. And county government is fortunate, we have all 3. One is corrections, and the other 2 are behavioral health and nursing home. So the county's got 1, and North Central is carrying the load on the other 2. So if you are looking for a report, it's really got some interesting data backing up what Vicki, Jason, and Gary were referencing, the importance of staffing. And if also there's a report today in the Wisconsin or the Wausau Pilot and Review about the challenges of local jails relative to staffing. So with that, we'll jump forward to United Way 211, and we have Megan here to talk about the programs that they deliver because as is in your packet, there's a proposed resolution should you choose to consider it, and that is related to the direction from the county board through their budget priorities and assumptions that each of the standing committees should look at whether or not they have a recommendation for administration through the budget building process, the annual budget, to continue funding the nonprofits that impact the departments under which each of the standing committees have, or over which each of the standing committees have jurisdiction. So given that Health and Human Services is certainly the committee of jurisdiction for social services, veterans, North Central Healthcare, and the health department, we wanted to have Megan come and give you an update on what it is that 211 does. And from that, I'm sure you'll be able to see the impact that it has on and county government, and you can make a judgment relative to the value of that program. So take it away, Megan, and I know your presentation is in the packet.
Okay. Looks like there's the start of it there. I don't know if I need a clicker at all.
You want to scroll through? You can do that here.
Okay.
It works too far away, so.
Okay. I can just sit down here 2 seconds. Okay, my name is Megan Schreiber, and I'm with United Way of Marathon County. I'm the 211 Program Director. I've been with the organization for 11 years, and I've been in my current position for almost 4 years now. And we really appreciate the support that we've received from the county. And I just have a very brief presentation here for you today to let you know about the services that we provide and how we do work with other agencies in the county to best serve our residents here, and we're able to serve residents in basically all walks of life. Okay. Okay, so what is 211? It's a national 3-digit dialing code. It's free, confidential access to health and human services. What we try to do is make it easy for people to get connected with appropriate community programs that can help them. So we have information about and referrals to services such as food and shelter programs, child or elderly care, family services, mental health resources, addiction resources, employment and training support, physical and mental health services, disaster assistance, donated good, volunteer opportunities, and more. So in a nutshell, we like to tell people when you don't know who to call, you should call 211. Okay, and just a little bit how people can access 211. We are available 24 hours a day by phone. We have the 3-digit dialing code. We have a local 10-digit code as well as a toll-free number that is accessible 24 hours a day. We provide text services Monday through Friday from 8 to 4. Online chat services Monday through Friday. Excuse me, it is currently 8 to noon. We are working on expanding that statewide to go through the afternoon as well. We have an online database that is available 24 hours a day, and we also have email that's available Monday through Friday, 8 to 4. So we've really worked over the past few years to expand access to 211 and make sure that people are able to get a hold of us in a way that's comfortable for them, especially with the younger generation. We see a lot more text and chat than we did just a couple of years ago. This is just a real quick visual of the 211 system throughout Wisconsin and how we're broken down into different call centers to serve different areas. And here's some data that is from July 1st of 2022 through June 30th of 2023. And this is the number of calls that we have had from Marathon County residents each month. And it's a little bit hard to see the exact numbers up at the top there, but if anyone has any questions, just let me know. You can see that it does stay fairly steady throughout the year with a couple of ups and downs. The big one was over the past 12 months was in October. October is not one thing in particular. It's kind of accumulation of different things that happen in October. One of the things that 211 does is we help register people in Marathon County, the elderly and disabled, to have their yards raked at no cost. So we get a big spike in October of people registering for that. We also had a lot of people calling that month about their utility bills. Utility providers get a little bit more aggressive in October to get those disconnections out and completed before the end of, or before the moratorium starts, and they're not able to do that anymore. There was also rent, shelter, and a lot of vaccine information. Once we hit fall, people are looking for flu vaccines and now COVID vaccines as well. So that was just a little bit about that spike that you see there in October. And this is just a little bit of how we compare statewide with the number of callers we have in Marathon County. Over the past year, it's been 5,600 and some odd change, which is surprisingly one of the higher call volumes within the state. You can see that Madison area is quite a bit higher, and I will be 100% honest, I'm not sure why the Milwaukee numbers did not show up on this graphic, but they did not, but I can tell you that they are the highest in the state. But we are hovering kind of right around the middle there, definitely more than our northern counties, not quite as much as the more highly populated counties. And this is a graphic that just tells you why people have been calling 211. Again, this, although we serve other counties, this is specific to Marathon County. The number one need over the past year has been housing. Housing encompasses a few different things. It might be that somebody needs help with rent to avoid eviction. They might be looking to move out of their current place and they need low-income housing options. They can't afford market rate rentals. They may be currently without anywhere to stay and they're looking for immediate shelter. So the housing category encompasses a variety of different housing needs there. The next one on the list is the mental health and addictions. Those needs we have seen go up significantly in the past few years. I think that is something that we've all seen in all areas, so it's no surprise that 211 has had an increase in those calls as well. The next highest is the individual, family, and consumer support, and that isn't real self-explanatory, so just a couple of notes about what types of services are included in that category. I mentioned before the yard registration. Yard work is included in that. People seeking services for case management, in-home services if they need housekeeping assistance or personal care due to disability or being elder. It includes support groups, economic self-sufficiency programs, benefits screenings, those sorts of services. And the next one there is the income support and maintenance. And what is included in that, the big one is the AARP and VITA tax programs. We have a lot of involvement and cooperation partnership with the AARP programs. And as a result, we get a lot of calls regarding those. Also included in that would be what we call undesignated financial assistance. Sometimes people are looking for just kind of an obscure financial need, and there might not be a program that says we help with that specific need, but sometimes we can help with those obscure things on a case-by-case basis, so that's included in there as well. Also, child care expense assistance, Social Security info, personal financial counseling. Those are the things that are included in that category. So those are the top categories of what people are looking for. And the next graphic here shows you a little bit about what services people were in need of and did not receive. Correlating with our number one need, our number one unmet need was housing. And the different reasons for unmet needs vary from person to person. It may be that they have already been served by organizations in the area and they're no longer eligible for assistance for another 4 or 5 months or whatever that might be. It might be that their household structure does not fit program criteria. It might be that they are looking for assistance with something, but the only thing available is for families with children, and maybe they're a single person. So there's a variety of reasons that needs go unmet in the area, and we do track those reasons so that if we have a need that is unmet quite often, and I'll give us an example, transportation. When we have unmet needs for transportation, it's almost always an unmet need because a program does not exist. We don't have a lot of transportation options in the area. So sometimes it's just the fact that there isn't a program that will offer you a free ride to work today or whatever it might be. Moving down there, you can see transportation is the third unmet need there. Clothing, personal household needs is number 4, and mental health and addictions is 5th in line there. And you can see the rest in order there too. I don't want to take up too much time by just going right down the line there. So please stop me and let me know if you have any questions. I would like to talk a little bit about agreements and partnerships that we have with other agencies in Marathon County. 211 partners with different agencies for a variety of different reasons. A lot of times we can help ease the burden on other agencies if we can filter some of their calls through the 211 system. We also have partnerships in place to make sure that we have a very good understanding of services that are being provided. One of the goals of 211 is to make sure that we provide accurate referrals. So we want to make sure that we have a full understanding of services so that we don't send people to a resource that they are not going to qualify for. So the first one on the list is the Department of Social Services. We partner with them, of course, to keep all of our resources updated. We have a special emphasis on calls regarding abused and neglected children. We do have a process in place for when we receive those calls. We are not mandated reporters by the state. However, we consider ourselves mandated reporters by our own policy and procedure, so we follow those same guidelines. And if somebody calls in, and sometimes they may call and they know that a report needs to be made, but they don't want to be the one to make that report. They don't want their name associated with it because it's their neighbor or a family member, and they're afraid of what might happen if it's found out that they're the one to make the report. They can call 211 and we will happily make the report on their behalf. We will also make the report based on our own judgment if we feel that's needed. What we really try to do, though, is we try to provide a warm transfer to Child Protective Services to make sure that they get through to somebody right away to make that report. We would rather do that than provide them with the phone number and hope that they do that on their own. If that's the case, then we're probably going to make a report as well, because we'd rather 2 reports be made than 0 if it's needed. We also have a very close working relationship with the Marathon County Health Department. Laura and I speak on a regular basis, especially over the past couple of years since the start of COVID. And the partnership that we have with them really entails utilizing 211 to get information out to the community that is accurate, up to date, and in real time. The health department does not have the capacity to take the same number of phone calls that 211 does. So when things come up, such as COVID-19, MPOX, the water contamination, we work very closely with them. And usually what will happen is they will call and say, we are getting a lot of calls on this, or we expect to be getting a lot of calls on this. Can we please direct people to 211? Can we put that out in a press release? And we will always say, sure, just give me the information that we need to make sure people have. And as long as we have that information, we're always happy to be the central location for people to call. That's exactly what we're here for. So over the past few years, that's been quite a bit. North Central Healthcare, we work closely with them to make sure that all of our AODA and mental health resources are up to date, and that we can provide referrals to them. We also work with their crisis team. I don't want to say on a regular basis, but on a regular enough basis. It seems to go in streaks. It really does. We do have people that call 211 and are in a crisis situation. We do have a mental health evaluation form that we do, like a mental health first aid evaluation that we'll do to determine what type of assistance that they need. And of course, if needed, we will warm transfer them to crisis. If they are not quite to that crisis point, we do have resources in place for warm lines and talk lines for people to talk to somebody before they're at that crisis point. And of course, to try to avoid getting to that point. And if needed, we will also bypass crisis and move on to a welfare check with the Sheriff's Department. The Sheriff's Department we work closely with in the same capacity. It is not unusual for us to call the Sheriff's Department and request a welfare check on our callers. We do have our fair share of callers that call on a regular basis that have some mental health and AODA issues that are ongoing. And between the Sheriff's Department and the crisis line and 211, we often have these same clients in common. And there was one common client a few months ago that we had that was calling, just as an example, he was calling upwards of 12 times a day. And he is somebody that has some mental health issues and needed suicide assessment on a regular basis. And we provided that for him. And he was in a state where we felt that we were calling and providing welfare or requesting welfare checks for him on a very regular basis. So at that point, we made a call to the Sheriff's Department. Are we doing the right thing here? Should we be handling this different? We want to make sure that we are not overburdening the sheriff's department and dispatch with calls on the same person over and over again. If they maybe have a different plan in place for this person that we could be aware of and work with them on that plan. The Aging and Disability Resource Center, we have an agreement with them just to ensure that we are up to date with all Elder Protective Service regulations, everything that's going on. That does go along hand in hand with North Central Healthcare as well. But the well-being of our senior and disabled population, we work very closely with the Aging and Disability Resource Center. Unfortunately, there are some services that are needed in the area for seniors and disabled people, and it does, services are sometimes hard to find. So a lot of times what we do is we work closely with the Aging and Disability Resource Center to say, do you know of something? Is there something that we're missing that we could be referring people to and we're not? And they may do the same thing. Hey, we've gotten a lot of calls from people recently that need help with getting their residential sidewalks shoveled in the winter. You know, we don't know of anything. Have you heard of anything? So we work with them very closely that way. And also the understanding of the scope of their services is very important, so that when we recognize our callers that maybe in the senior or disabled population, they may be calling us for what seems to us to be a one-time need. They may be saying, I need food. But when you're part of those populations, we like to find out a little bit more about their situation and see if extended services might be more appropriate for them. If you have somebody that's elder or disabled and they're having problems with food, do they have the supports in place to help keep them in their home as long as possible? And the last one on the list here is through the Central Wisconsin Airport. That is really from a standpoint of making sure that the community is just informed of transportation options. Again, Central Wisconsin Airport is the transportation hub for long distance travel in our county. With our callers, a lot of times they're lower income, and they may not necessarily be looking for airport services, but we do also have people that are calling about what our area has to offer and what we have going on here. So we do also have resources about cultural things in the area, the Grand Theater, the Lee Yawkey Woodson Art Museum, the history museums, those sort of things. And that just ties in with Central Wisconsin Airport in just promoting and making sure people know what's available to them in our county. So. See if I can scroll down a little bit here. Special projects that 211 works on. 211 is the contact for the Wisconsin Addiction Recovery Helpline. And that is a grant that's received through the Wisconsin Department of Health Services. And what that does is it designates 211 as the place to call when you need your help finding AODA resources. We all know that addiction and mental health resources as well are very limited and hard to come by. And when you combine that with people that have addiction issues, may not be able to hold down a job and therefore not have health insurance, that makes the search for adequate treatment even harder. So we have beefed up our database and taken special training on how to help people and navigate the different types of substances that they are using. We drill down to what they're using, how they're using it, what might be the best course of treatment for them to start with. We are not AODA counselors, so we don't give our opinion. We don't give counseling, but we let them know that these are the options that are available to you, and based off of what you've told me, this would be a very good place for you to start, and we try to do a warm handoff. People that are experiencing addiction issues sometimes will only have maybe a 10-minute window where they're thinking, I can do this, I'm ready for help, and I need it now. So we try to get those people connected directly. We don't want to hang up the phone with them and have them lose their motivation or courage to call for help. Disaster damage reporting, we work with local emergency management as well as Wisconsin Emergency Management. Anytime there is major disaster damage in our service area or in the state of Wisconsin, 211 is designated to take those reports. So when there's major storm damage in the area and people have reports that they need to make, we collect all of that information, what the damage is, the scope of damage on their property, whether they have electricity, whether they have a working well, if that's underwater, if they can access their house, if they cannot. We collect all pertinent information. We turn it over to emergency management, and that is the information that they use to apply for federal funding for disaster relief. And it makes sense to have 211 do that. We already have the telephone structure in place, and also the people who are calling in with storm damage may very well also be in need of resources if they've been displaced from their home. Make a Difference Day. I touched on that a little bit before. We help out with that program, which the program itself is a initiative of the United Way, and we have volunteer groups that go out into the community and rake yards for the elderly and disabled in our community during the fall, so that it's just one more thing that helps them stay independent and stay in their own home. And 211 allows people to call in, and we will register for them. Again, a lot of, they're elderly and disabled, so asking them to go online and do that themselves isn't always the best course of action. AARP Tax Aid Program, we've worked with them very closely for many years. Currently, the partnership we have with them, we provide training for all of their volunteers on how to schedule appointments. We allow them access to appointment scheduling software that we currently utilize, and we also provide them with office space and our phone lines so that their volunteers can have the tools that they need to come in, take the phone calls, and make the tax appointments for seniors and low incomes in the area to have free tax preparation done. I already touched on, we are designated contact with DHS and the health department for COVID, MPOX, water issues, anything that comes up. And then something that's new within 211 is anytime anybody is interested in the needs and what's going on in their area as far as 211, there is an online data that is available. It's a community dashboard where you can look and see what types of calls we've been receiving, how many referrals we've provided for different types of needs, and things like that. And I think, yes, this is my last slide, which I'm not going to read through here. I hope that you can see it well enough to just take a glance while I make a few more comments here. These are just stories from our callers and their situations and how we've been able to help. And one of the things that I wanted to touch on is when people hear about 211 and we give community resource information, sometimes people will say, can't I just Google that? Well, yes, you can. You can Google food pantries in Wausau, Wisconsin, and you will get a list of what's available. What the difference is we all know that the internet isn't always up to date. Not everything that you'll find online is up to date. We take the time to make sure that our resources are updated once a year, as well as needed throughout the year, I should say. For example, there's been a lot of changes recently with the Neighbors Place. They've moved locations, they've changed their program a little bit, and they've changed their hours. We're not waiting a year to update with them. We make sure that we're in contact with them. And the other reason why we don't want people to just Google things is when you call 211, we're going to take the time to make sure that we don't send you on a wild goose chase. You might Google rent assistance and come up with 6 different places that might be able to help you. Well, after you call 4 of those places and they say, I'm sorry, you don't fit our criteria, you're going to start to feel a little bit defeated, overwhelmed, and kind of lose motivation to keep going. We try to drill down and get an assessment of people's situation. If somebody calls for rent assistance, we're going to ask them if they're currently behind on their rent, if they've received an eviction notice, do they have any children in the home, do they have any veterans? All of those play into eligibility so that we can determine what programs would be a good fit for them. Also, we're going to take the time after we give them those rent assistance resources. If they're struggling with rent, that might be the #1 thing on their mind right now, but they may be struggling with something else. So we're going to ask them, what other needs do you have? Are you doing okay on food? Are you currently enrolled in any statewide benefit programs? Do you have food share? Have you applied for energy assistance? Because we know that people that are having a hard time financially, if they can save a little bit of money in this area, a little bit of money in this area, and a little bit of money in this area, it can add up to a lot of savings for them and really help them not find themselves in that position of needing to reach out for rent assistance again. So that's the approach that we take to helping our callers. And I think I'm going to stop right there. I don't want to take up too much of everybody's time today, but does anybody have any questions?
Madam Chair, if I can add one thing. Going back to the slide that Megan had about those agreements with all the various organizations, the Sheriff's Office, the Health Department, I just want to make very clear, that is exactly those are the agreements that come from that contract that administration, based on the direction from the board about putting in place those performance measures for that service contract. That's where all that came from, which I think Megan did a great job of demonstrating how we've used how we've moved away from here's the $40,000 that we give annually to the program to say, here's $40,000 and this is really how we leverage that. And you can get a good sense of the immense value we get from 211, where we direct people to it. And all the work that Megan and her team do to answer all those questions, people would be calling us. And instead of us saying, you know what, call 211, they're ready and equipped to answer all these questions, we would have to go through all of that. So every call at the health department, and the health department still answers a lot of those, but a lot of people can call 211, and it frees up county staff to do a lot of the other work that people are counting on us to do. So I just wanted to highlight, again, your annual contract is $40,000 that you allocate through the budget for 211, and each of those things are directly pulled from it.
Any other questions?
Thank you, Lance, for that clarity, and also thank you, Megan. Great job in presenting. Oh, we do have a question, Donna.
No question. I just wanted to thank you for a wonderful presentation.
Oh, thank you very much. I appreciate that.
Okay, moving on to 7C, North Central Community Action Program, update on the service provision.
All right.
Good afternoon, and thank you for.
Oh, go ahead, Diane. I was just going to kick off and say Diane is online. Hopefully you were able to hear us. And if you are looking for another
Yes.
presentation that Diane did, she already presented to Public Safety back in February about the programs that North Central CAP does on behalf of Marathon County. Very similar. We have that performance contract, that service contract through the annual budget. And North Central CAP's funds, Diane, you'll have to correct me if I'm wrong, $33,757, right?
That's correct. Thank you. So, and I can send this presentation out to all of you too. I had a state monitoring today, so I wasn't able to be there in person. But I was just going to go over the contract that we do have with Marathon County government. And I'll be real quick because I know this meeting's been long. And I just wanted to basically tell you where the money was spent. So we're a community action agency and respond to the needs of the communities we serve. And we're also charged with working with the state and federal government for our grants and our local governments. So we know what the community needs are. So in our contract with Marathon County, the first item is we will partner with North Central Healthcare Community Treatment to provide services for clients of community treatment within Marathon County. And specifically, North Central CAP will provide housing-related services, including rental subsidies and case management. And in 2022, North Central CAP assisted 28 households with a total of 840 housing days. And that was for a total cost of $18,200 of that contract with Marathon County. The number two item that we contract with Marathon County is we will partner with North Central Healthcare Crisis and MMT departments to provide services to clients utilizing crisis and MMT programming. Specifically, again, we'll provide housing programs to these folks. And these folks are utilizing inpatient care either in crisis or a medically monitored unit. And when they're coming out, that's when they need the assistance. So we served 8 individuals in 2022 for a total of 240 housing days. And that came up to $5,200 of the Marathon County contract. And I know this is really quick and brief, but I will send this out so all of you can have it. I do have more verbiage to explain exactly what we did and how these folks are helped with our services. But I do want to be brief today because, like I said, I know this meeting's gone on quite a long time. Number 3, North Central Cap will partner with Marathon County Department of Social Services to provide services to community response social workers. And this is a large part of what we do with social services. We typically provide rental subsidies or a housing program for these folks. And we also provide case management to go along with the social workers too. So 26 households were placed in housing in 2022 for a total of 4,680 housing days. $10,357 of the Marathon County contract was spent in this category. The balance of $52,578 we used a North Central Community Action Program's prevention program. That's a grant that I write at the state level. So that helped quite a few families. Number 4 of the contract is we'll partner with Marathon County Jail and Probation and Parole to provide housing and case management services to individuals being released from incarceration. So we work with Rhonda up in the Marathon County Jail to line up housing and get paperwork ready for rental assistance before inmates are released. Some inmates are working and will be okay going forward. Others we hope to get connected to employment with our case management services. And here again, we do provide budgeting and connecting them to other services when needed. So that's a huge thing for people coming out of the jail. We did help 16 individuals who were released from Marathon County Jail for a total of 480 housing days. This cost was approximately $10,425, and we did use our private funding to cover this cost. But this is very important because in all these areas, we provide services for Marathon County. The ultimate goal is to keep people stably housed and employed and contributing to the community. And for those involved in the court system, we want to keep them out of jail because once they're incarcerated, they do become a liability for the county because the county is ultimately responsible for the jail. So aside from that financial component, we do want our county to be safe, healthy, and prosperous and be a preferred place to live. So we want people to be, contributing to their own environment. We want people to be self-sufficient, and we do try and help those folks with case management. And of course, we do provide the rental assistance. And the last part of our contract is we'll provide case management services and skills to training for county partners and service recipients. So we do have a lot of training available to us because we're involved in a lot of coalitions, and I push this training out to all people because most of it's free and they can attend online with Zoom classes. And I can send you a list of the training that was offered through our organization and our partners in the communities we serve after this presentation. Lance, you'll just have to let me know if that's something you'd like me to do or if it would be helpful. I can certainly answer any questions that people might have, but I do want to provide a short summary of services that we provided to Marathon County outside of our contract. Because of the $33,000 that we get from Marathon County, we're able to write for a lot of grants, and that every dollar that we get from Marathon County allows us to get, $4 more in other grants from the state and federal resources. So that's huge. So in Marathon County alone, in 2022, we did spend about $170,000 for 131 households to keep them housed. With the WERA program, that was a COVID program. We assisted 258 Marathon County households with rental, utility, and water, totaling $795,000. In 2022, we served a lot of people with the Wisconsin Help for Homeowners, but that's COVID funding that is still going on, and that helps people who have mortgages, which we've never been able to help people before, but we did assist 159 Marathon County households with mortgage, property tax payments, utility, and water for a total of $586,000. We also weatherized 122 homes for a total of $1.3 million. We helped 101 households with emergency furnace repair and replacement services. And we provide transitional housing for 10 rental units in Marathon County. Those are all located in the city of Wausau. And we expended over $191,000 for those 10 units to help those who are chronically homeless overcome their addictions and try and get them to be self-sufficient. So we're also a fiscal agent and provider of emergency services for the residents of Marathon County, and that's a benefit since we're able to assist the county health and social services departments in crisis situations. I know that was really, really quick, but does anybody have any questions that I could answer?
If I can add, Madam Chair, and a little plug for Diane, two areas that I wanted to highlight where I think they do a great job, and you can see the impact, again, how that money is leveraged. Our drug court, for example, you know, when Diane's talking about working with Marathon County Jail, probation, parole, helping people, as Vicki alluded to with North Central, you know, when people come out of a treatment environment where they have been removed from kind of some of the challenges that they have in they had previously in the community, that's a real dangerous time. It's a tenuous time when people have to look, where are they going to go back to? And Diane's team has done great with our drug court population. She's done great with our county jail, probation, parole to help people find housing that will allow them to have a better chance, a better likelihood of success. Another example of a program that they did, and it's in the budget book, and I pulled up the budget book, Diane. It's on page 130 of the county budget book where we go through all the contracted services that you just referenced. But we made reference to the work that Diane and her team did with the Community Development Block Grant, another area where we leveraged what North Central CAP was already doing, tapped into them to essentially run the subrecipient. They were our subrecipient for block grant dollars. Social services worked with them, but to get those funds out in the community. And then lastly, I'll say, you know, it's a different program. It's not covered under this contract. It's a separate agreement, but our Family Keys program that you've heard a lot about, when we have families who are, again, in that stable housing area and they're looking to make sure they have a place to really be successful and ensure that they're able to get their kids back after doing everything they need to do to get their kids safe. Social Services has been working with Diane and her team, and it's been going swimmingly well. They do an excellent job despite the very difficult housing market that exists. They are able to, with their relationships with local landlords, tap into that and find people housing, which is no small feat. So I know Diane's presentation was short, and we can certainly send you more information, but I just wanted to say they really do a really great job kind of being that bridge when we need to have, and a lot of it is related to housing, but that's really, really, really important as people leave a lot of our, you know, whether it's our MMT program through North Central, crisis, or through our jail or Family Keys, you name it, drug court, they really do a nice job.
Thank you, Lance. And I didn't say anything about Family Keys, but that is really going well. We have our 9th family enrolled right now. So we do have an excellent relationship with many landlords, and we do have a very good relationship with several private landlords. So we are able to house these families. We explain the program, and the landlords listen, and they're willing to work with us. So it's going well, and we're quite happy about that.
Thank you, Diane. Thank you, Lance. Are there any questions for Diane or Lance? Seeing none, we'll move on. We're going to jump back to 5, policy issue discussions and potential committee determination. 5A, request from executive committee for this committee to consider how to persuade the state of Wisconsin to restore supplemental payments and certified public expenditure payments to county nursing homes. Lance?
Sure. Thank you, Madam Chair. I can kick this off just to give a little bit of context. As you likely remember, you actually at this committee took action to move forward a resolution, and the board adopted a resolution calling upon the state to restore those supplemental payments and certified public expenditure payments based on the losses that North Central Healthcare has been really challenged with relative to operating Mount View Care Center on behalf of Marathon County. I mean, again, as Gary said, North Central Healthcare is an arm of the counties, and one thing that Marathon County has decided to do is operate a nursing home for a wide variety of reasons. North Central runs it on the county's behalf. They also currently run the nursing home on behalf of Lincoln County, Pinecrest. And at the end of last year, there was a lot of discussion about those supplemental payments. And this county board, at the urging of North Central Healthcare, sent that resolution to state legislators. There was recently a discussion at the executive committee about, really needing to revisit and rededicate ourselves at the county level to addressing those issues because of the significant impact they're having on North Central Healthcare and by extension the county. And you likely have heard about some of the discussions in Lincoln County about Lincoln County selling the Pinecrest Nursing Home and North Central no longer having to operate that. That too is going to have significant financial impacts. When we talk about indirect costs, Jason brought those up. That really changes that indirect cost structure. So the discussion at executive was, how can we continue to keep the state of Wisconsin informed about the impact of these changes in supplemental payments and certified public expenditure payments to the county nursing homes? And they asked that this committee kind of take that up again. So really that's kind of the context. I don't know if Gary, Jason, or Vicki or anyone wanted to add anything, but we can talk about and brainstorm, what might that look like? I think there are a number of things that the county can do to keep that at the forefront, but there was an effort relatively recently, and certainly through the budget to restore those payments. Unfortunately, that didn't go in the direction we wanted. It wasn't successful. And it's not only a one-time thing. This is every year. And again, you can look in your budget book. We make an annual allocation not only to community programs, like Vicki talked about, Vicki and Jason, Gary talked about, but also you make an annual allocation to the nursing home. And without those supplemental payments, I'll just be very blunt, the financial impact on North Central is very, very significant. So that's the discussion. Madam Chair, I hope that laid the context, but if people have thoughts on what that engagement might look like, happy to offer my 2 cents and we can have that conversation.
Any comments? Go ahead, Ron.
Thank you, Madam Chair. Thank you, Lance. Have we contacted our state reps in the area on this?
Yes, the resolution that the county board adopted, and it was also adopted by Lincoln County's board and the North Central board, was sent to the local representatives. I think the question of anytime you adopt a resolution and mail it to people, the question is, what do they do with it? And I think that, again, at executive, the thought is, well, are there other ways to get in front of legislators? And I think the answer to that, the short answer is, of course, yes. But it was sent. And I don't know, it looks like Supervisor Robinson has a follow-up.
Okay, thank you.
If I could follow up on that, Wisconsin Counties Association has a county ambassador program where we meet with legislators on topics of concern. And there was one on health and social service issues, and I was in attendance and presented background information that Gary had given us. So we not only had the resolution going, but direct contact with either the legislators and or their staff in April.
Okay, and the follow-up, have we heard back from our representatives?
I haven't heard from them about this particular issue. I know Representative Callahan, who represents a portion of Lincoln County. My understanding is he recently tried to bring this issue again forward, but that didn't gain any traction. I've spoken with our local representatives about it just in passing, but in addition to kind of what Supervisor Robinson talked about the CAP program, I do think there's an opportunity to, quite honestly, a low-hanging fruit, schedule a meeting with Representative Snyder, Senator Tomczyk, Representative Spiros, and invite them down to the North Central Healthcare campus, perhaps our new conference suite or one of the other things one of the other rooms down at the nursing home, and go through the financial impact. But Gary, it's about $1 million, right?
Oh, yes. Well, $1 million for Marathon and another $1 million for Pinecrest. So it's a lot of money. This is an important, we've pushed a lot. I really thought the Representative Callahan's budget bill would go forward, but the Finance Committee wouldn't even take it up. So now we also contacted there were 16 counties that were impacted by this. So it's not just 2 that we're talking about, 16. And I thought that there would be a little bit more, groundswell, if you might say, to try to move this forward. And I was kind of surprised that it hasn't and it's died. So if you would like to do that, we would get our dietary to do lunch. We could get them here with the thought of food and have a conversation with them. We would gladly host that out in the North Central.
Yeah, I think that would be my suggestion, is to invite them for the discussion. I do know all 3 of those personally, and I think it's an important subject and a costly subject that I think if we extend that invitation and try to work out a schedule with them to, present the information that they need to hear, I think that would be a good conversation to have. Thank you.
How soon could we get moving on this?
Gary and I can make some phone calls pretty soon. Again, I think that's the low-hanging fruit. It was meant to brainstorm. The other thing that you recently did, the county board took up sending a signed letter as opposed to a resolution. I don't know if that's a functional difference for legislators. We could take a similar approach. But again, I think executive committee was just saying we need to your point, Supervisor Covelli, we need to keep this conversation going. The resolution clearly didn't have the impact we wanted it to. So what does it look like to keep it going? How do we keep that conversation happening?
Is this something that we can invite the 16 counties to?
We certainly can try. We have the list. Whether or not they would show up here or encourage them to have their conversation with their own representatives as well.
Go ahead.
Okay, sorry. It might behoove us also, if we're going to do it, to include Lincoln County, because they would be, this impacts them huge. And so we could look at getting their reps here and them at the same time and get as many people. Lance, you and I can kind of coordinate how we could pick a date and see how we could get this coordinated to get. The main ones would be to make sure that we got our representatives, and if we could get Lincoln counties there, because you're talking a lot more firepower at that point, because you have 2 counties looking at it. And I know that they've been pushing also. So I know that their chair, Frisky, would be interested in something like that.
Supervisor Robinson.
My suggestion is you expand that list to all legislators serving the county. Senator Falkowski is on Joint Committee on Finance, which you may need to go to, and Senator James is new and serving the western part of the county, and then making sure you get the other representatives. And I would suggest also inviting the governor's office and DHS to that meeting to because it's an administrative interpretation and change that impacted us. So I think you need all the parties present if you can get them.
Supervisor Covelli.
Do we need a motion or not?
I think it's just for discussion is fine. This has been very helpful. I mean, you're saying the things that I think we were kind of thinking would be helpful. I don't know, Corp Counsel is looking like he's itching to take his turn at the mic.
I would take this as direction from the committee for staff to move forward in that direction. So I don't think a formal motion is required, but if you wanted to, certainly that would be in order too.
All right. We'll move forward then.
One other thing that I wanted to suggest, and I appreciate your feedback. I think there might be value in making it not only a meet and discussion with legislators and, as Supervisor Robinson said, administrative representatives and executive branch representatives, perhaps also tap into our communications staff, both at the county and at North Central, to perhaps get the media involved. I mean, this is not a small, as Gary said, this is not a small financial impact to the county. And, I'll say again, when we put the revised financial plan together, Gary and I and representatives from North Central and our finance department about our ability to service debt, this came after. So we had it was going to be a heavy lift before. Without these supplemental payments and CPE payments, the ability to do that is a real challenge. So I think the media might be a useful tool. I don't know what the committee thinks on that.
I agree. Do you all agree?
We'll evaluate how to best do that. So, no, thank you, very, very helpful. If there are any other suggestions or thoughts, please reach out to Gary or myself.
Okay, thank you. Moving on to 6, operational functions required by statute, ordinance, resolution, or policy. 6A, consideration of requests for additional social services, CLTS/CCS related positions and corresponding budget amendment.
All right, this is your marathon meeting. So this is very helpful that it dovetails nicely with the presentation that Vicki just gave about some of the programs at North Central. But Krista Jensen, Amber, and Colleen are all here to talk through this request for you. And I just want to start with, you might ask, why are you here? Well, your county board ordinances require that for any new position, that it has to go through a very deliberate process. And that deliberate process starts with a review with me. Krista and her team met with me to talk about these position requests. I certainly wholeheartedly, endorse it. It went through the Social Services Committee to get their kind of programmatic support, and it received that. You are the next step, then it goes to HR Finance, and then ultimately the county board. But Krista will give you kind of the background. Krista, Amber, and Colleen will give you the background as to what CLTS, or Children's Long-Term Support, is, and kind of why the position request is here and how they would implement it. So go ahead.
Thank you, Lance. Good afternoon. Can you hear me okay without this? Gotta use, I'm on camera.
Okay.
Great. All right. Well, thank you. I do think all of the presentations leading up to this, hopefully, I think maybe close to your last one for the day, will be really beneficial. We talked a little bit about the importance of staffing in some of the other presentations, and so this, of course, is very timely for that. The CLTS program, I wanted to give you a little bit of context, just what it was, right? So Vicki had spoken about the services that North Central provides, and they do provide CLTS, or Children's Long-Term Support programs, to the other counties. However, in Marathon County, Social Services is the waiver holder for CLTS. So North Central Healthcare does not run any CLTS programming for the eligible children of Marathon County. The CLTS program is a wraparound services program to children who have substantial limitations in their daily living needs. They need supports, they need services to remain in their home and in their community. This is run by DHS, and it uses the Medicaid funds to offer a wide range of different services, and then county waiver agencies or social services help the families access those different services. So that's really how it is funded. It's funded through federal and state government. It's totally voluntary for families, and there is no tax levy that goes into this specific program here in Marathon County. So a child's eligibility is based on their functional limitations, so physical, developmental, emotional, that just really limits their ability to carry out their daily living activities without additional supports. This depends on what the child's specific goals are. And it goes beyond what health insurance or Medicaid might cover. So that's what that funding is for. So first, those pieces are billed, and then it goes to the federal funding. Some examples of different services that CLTS can provide might be home modifications, like a wheelchair ramp or a bathroom modification to allow them access. It might be caregiver services, such as respite, to provide those primary caregivers that opportunity to regroup themselves so that they can provide regular care to these children who require really intensive supervision on a very regular basis. It might also be adaptive aids like a service animal or adaptive bicycles, adaptive high chairs, things of that nature. So those are the primary things that this program covers. Our CLTS case management rate is calculated. We send that then to DHS, who approves that rate. And so that's how we ensure that there's no tax levy that covers these programs, is by calculating that case management rate, which does cover all of the indirect costs as well. So, Colleen, who's behind the scenes doing a lot of the finance pieces, her costs for this program are included and covered. Here's a little bit of an overview of the Marathon County CLTS program. So currently in social services, we have 14 social workers who work with the families. We have 1 lead worker and 1 supervisor position. That's Amber Pax, who's here with me today. And then we also have 2.5 CLTS accounting specialists. And so Colleen, who's also here today, she oversees those individuals, and she is really the brains behind the finances. But we serve 79 CCS youth. So Vicki spoke about CCS a little bit. The difference is the CCS youth served by Marathon County Social Services are also dually eligible for CLTS. So we don't serve any youth who are only CCS. They also have a CLTS caseload as well. So sometimes we have youth who are only CLTS, only involved in the CLTS program, but are eligible for CCS. However, because it's voluntary, have chosen not to participate at times due to provider limitations. For example, if an individual comes to us who's been receiving counseling services and they're CLTS eligible, we also find them CCS eligible, they could choose to bow out of the CCS program because maybe their therapist is not a CCS certified provider. And so then we would only provide them services under the CLTS program because otherwise they're required. So each of our families, our social workers in Marathon County have an average of 33 cases each. And so a case is considered if a family might be dually eligible. So say I'm dually eligible, then I would be counted as 2 cases because our social workers are running 2 separate discrete programs, one being CCS and one being CLTS. So on average, they're managing 33 cases each for those 14 social workers. So our numbers are pretty wide. As you can see, we have 383 CLTS youth currently and the 79 CCS youth. In January of 21, so there used to be a wait list for these services. However, in January of 21, DHS said, we don't want to do that anymore. We want to make sure that the youth who are needing to be served are served because of their excessively high needs. And these programs really can help to keep them here in our community, avoid high cost placements down the line for them. So they put this into place, and through the state budget, DHS has been awarded funds to help eliminate that wait list so that we continue to be fully funded for these programs, even though we have a significant increase in the youth. So DHS is monitoring Marathon County's compliance with achieving that continuous enrollment and no wait list status. In June of 22, we had effectively eliminated our wait list, so we were pretty excited about that. But we have continued to see regular referrals to the program, higher than anticipated, and so a wait list was restarted for us in January of 23. So currently in Marathon County, as of yesterday, really, we had 63 children waiting on that wait list to be served. On average, children are waiting about 5 months from the time that they are referred to service before a social worker reaches out to them to schedule a time to determine if they're eligible for those services. So it's a pretty significant amount of time when you have pretty significant needs to be waiting for what those services look like. All children referred have to be assessed. So even if we don't think they're going to be eligible, we still have to complete the assessment process for them. And most children referred are eligible for the program and ongoing case management. So as I mentioned, we have the wait list as our referrals have been really steadily increasing. And you can see the numbers up on your screen about the numbers that we have received every month. And so from 2019 to the end of 23, based on these numbers and based on projections, this program is projected to increase by 285 clients, or 141%. And so due to this wait list, as Lance had mentioned earlier, the Social Services Board really encouraged us to come with how many positions would we need to really make sure we can eliminate that wait list and provide continuous services. So we did come up with some formulas for us to be able to ask for how many positions specifically it would take to eliminate all of those. And so what we are asking for to help us eliminate that wait list, provide the oversight, and I'll give a little bit more detail about what these specific positions do. We are asking for 8 positions total. 1 CLTS accounting specialist, 6 social workers to help eliminate that wait list, and 1 supervisor. As I mentioned, there's currently 14 CLTS social workers, and so this increase with 1 supervisor would be pretty significant. So I'll dive in a little bit to what each of these roles currently do and why we need them. As I mentioned previously, we currently have 2.5 accounting specialists. And so our accounting specialists provide administrative support to the social workers by entering those service authorizations. So let's say there is a bathroom modification that's needed. They enter that authorization to allow that contract to occur so that the service can actually happen. Then they upload that so that we get that payment back, essentially. They calculate and bill the parental payments for CLTS. They place orders for products. Could be things like that adaptive wheelchair or diapers or something of that nature. And then they help to complete the billing process for all of those pieces. So we're really there, everybody behind the scenes who are making sure that we're getting reimbursed for the services that we're providing and that we're fully funded. They also do all of the case management billing process that we talked about earlier, which includes the remediation of any denied claims. So at times claims can be denied, and then they work through Medicaid to make sure that those are moved forward. And as I mentioned, that case management is that mechanism in which we get reimbursed. So they also work on all of our contracts. So when we are working with CLTS youth, we obviously might need a contractor to do that home modification. And so our accounting specialists are working through all of those contracts for us, doing any amendments, service agreements, et cetera. And currently we have 58 active service agreements. As our youth and families in the program grow, our service agreements are likely to grow as well. So as you can see on the chart, maybe I'm having a hard time seeing it, but the increase in clients has really decreased the number of hours that our accounting specialists have available to spend on those tasks because they've really increased significantly. So we have offered overtime to our staff to help make sure that essential tasks such as service authorizations and entries, orders for goods, equipment, et cetera, are all completed timely so that these children can remain safely in their homes and families can provide for them. But we do have a significant backlog on the processing of our claims to that third-party administrator for the goods, equipment, and foster care costs. So we have 1 year to submit for all of the claims. And as of this time, we have not submitted for any claims in 2023. And we are, as of December of 22, we were about $500,000 in outstanding claims that we had not yet been able to file for. So this additional accounting specialist position will really help to make sure, as we've mentioned, that we can bill for all of our claims, that there is no tax levy that goes forward to any of these positions, that families get the services, the goods that they need so that these children can remain safe in their care. I'm going to pause for just a second because that's a lot of information and see if you have any specific questions on the accounting specialist position. Okay, great. I will move on then. So again, that's one position we are requesting. I'll move on to the social worker positions, which we are requesting 6 of, which was based off of our discussion with the Social Services Board, who prompted us to ensure that we were asking for the right number of social workers to make sure that we could really meet DHS's requirements to eliminate this wait list, as well as ensure that our staff can have appropriate size caseloads. So as I mentioned previously, they're all carrying caseloads, about 33 cases on average currently. Our ideal goal would be to get them to 30. We know that that's still significantly above what we would ideally like them to manage, and it's significantly above what SAMHSA recommends. So SAMHSA is the Substance Abuse Mental Health Services Association, and they had done an evaluation for CLTS and CCS programming in, I believe it was 2014, and they made a recommendation on how many cases should be managed. Their recommendation was to have 8 to 12 families, depending on the complexity. Now, again, this is just taking into account CCS and CLTS, so that's important to remember. And then they also made a recommendation in regards to supervisors that they would manage 6 care coordinators or fewer. And so right now, Amber is managing 14, and of course, if we move these forward, that would be 20. So these additional positions, you can see how we really calculated it. It would help to ensure that we're moving forward on that continual enrollment process, or regularly maintaining the no wait list status, and then balancing those caseload numbers. So we identified, based on the projected number of new cases, that would be 133 cases, based on the referrals that we're receiving and the current wait list. And if we wanted 30 cases per worker, you divide that, and we would need 4.5 workers. Of course, we can't have a half a worker. So it actually works out nicely, however, with the number of workers needed to balance our current CLTS staff to 30 cases per worker. Currently, they're at 477, which gets us our 33 on average, so they're 3 over. Multiply that by 14.5 workers. Then we know how many cases need to be redistributed, divide that out, and we're at 1.4. So that gets us to our 6 staff that we really need in order to successfully eliminate and ensure that we can have reduced wait times for our long-term support services, and make sure that we're having the impact that we need to have on these families with really high complex needs to avoid out-of-home care in the future. Then that moves us to our rationale for our supervisor. Again, if these positions were all to be approved, we would have 20 CLTS social worker staff with 1 supervisory position and 1 lead. And so we know that this program really plays a crucial role in providing comprehensive care and support for these individuals with specific disabilities. The ratio is really important for the quality that our social workers, our case managers receive, so that they can have the effective training, help to streamline our operations, help to make sure that we have good positive service delivery, that we're reaching out to all of the right service providers and getting those contracts in play. And really ensuring that we are providing quality assurance, completing our audit requirements. There's an audit that happens annually for this. And so they do all of those pieces. A 1-to-10 ratio is ideal, providing supervisors that time to dedicate time to staff development, foster a supportive workplace. It's hard to get to your supervisor when you're one of 14 to 20, and so limited time. And then I think it just really offers an increased collaboration with our community partners, with families, all of those stakeholders. So, by approving these positions, I think there's really 5 important pieces, I think, that are take home. There is no cost to be offset for any of these positions due to the funding nature of this program, so no tax levy involved. The CLTS support position will allow for the timely submission and reimbursement of all of our associated costs. It'll help us to get caught up on the $500,000 that we have not yet billed, which we have 6 months left to do. Well, less than that, because we're already in August. A few months left to do that for, as well as then make sure that our 2023 claims can begin. It will allow us to not be placed on a corrective action plan by DHS due to not meeting the requirement of not having a wait list. So we could choose to not do anything, and then DHS would come in and tell us what we would need to do, or we can be proactive in doing that. Most importantly, probably, we're positively supporting families and children with complex needs, decreasing the likelihood of out-of-home placement. And if they were to go into out-of-home placement, that is increased in tax levy. So we're hitting that on both sides. And then staff having manageable caseloads and supervisory support really limits that turnover due to burnout when you're serving this number of families. The CLTS programs, as well as the CCS programs, change frequently. There are a lot of different dynamics to the programs. There's a lot of different red tape that happens. And when they have an appropriate caseload with appropriate supervisory support, we keep our workforce in play. And so that is CLTS in a nutshell. Really, I think that there's an important component to remember that CLTS is a separate program from CCS. CCS providing more of that mental health-based service, and CLTS providing that more of the physical, cognitive, disability-based services. We do not, just to make it clear, want to hire all 6 social workers at one point in time. We don't have the capacity to do that. We want to make sure that we can appropriately onboard them, train them, get them up and running. We also want to continually evaluate our data to make sure that those programs would continue to be needed. And so we are open to the discretion of this board as to how you believe it would be best for us to recruit for those positions and in which order. It would be my recommendation that the CLTS administration position be one of the first positions that we be able to fill if approved by this board in order to ensure that we are able to adequately bill for the services and that families can receive the services that we do authorize. I believe a social worker position at a minimum would be the next most important piece because that's really what's going to help us to eliminate our wait list. The supervisory position is a very important position, but I would say that it wouldn't be my top priority if we had to make some choices because we do have some other mechanisms that we could look at to make sure that Amber is effectively supported, that her team is effectively supported until that supervisory position could become on board.
Thank you, Krista. Are there any questions?
Madam Chair, if I can build on one thing, what Krista just ended with, and your process, it's my old lawyer hat on. Your ordinances kind of lay out the process here, right? And I want to talk and build on operationally what our process would be, and Krista hit it right on the head. We're not going to hire 8 people all at once, but your ordinance requires us to get permission for adding full-time equivalents, regardless of the fact that there's no levy based on how the program operates. And I want to also highlight one thing. This is, of all the areas of funding that the state has, this is one that I feel really good about in terms of sustainability and commitment from the state. This is a good one. They have demonstrated that commitment in the past. So I figure you might have that question. How likely is this funding to continue? All indications are that the state is 100% in on this to continue that full, essentially a full reimbursement. But operationally, I think Krista and her team, Amber and Colleen, have put together a nice, you understand the projections as to why they are asking for the 8 positions, the kind of various types of within that 8. But operationally, how we're going to do it. We're not going to hire 8 people all at once. We're going to phase it in. If something happens and oh my, the wait list is impacted in such a way that we don't need 6 social workers, I mean, I can give you the commitment. We're not going to hire those additional people, and we'll come back and we'll let you know that. My request, building on what Krista is I'm asking you to move forward this position request through the process at all 8, all at once, because I don't want to be in a position where we onboard the first 4, we're on track based on the projected need, and then we need to go through the process again, which is this committee, HR Finance, and the full board. I mean, it essentially puts us behind, even if we had all of our ducks in a row, it's a month to get through that process. My commitment to you is that we will do the due diligence we do all the time, which is anytime we're going to post a position, we evaluate, do we really need it? And then we move forward with posting. That said, we wanted to be very transparent with you. You, of course, could say, we approve 4. The supervisor, the administrative support, and the 2 social workers. Or you could say, hey, we approve the full 8. And if we don't need 1 or 2 social workers, my commitment is, and my promise is to you, we won't hire them. But the need is there. The financial stability is there. Happy to answer any questions. I'll just say, when I was on I served on what previously was called the Retained County Authority Committee at North Central, and the approach that we took at the time in terms of North Central addressing this kind of ever-changing need, if they need new CCS positions or CLTS positions, we essentially adopted a policy where we said, hey, you are free to add positions as staffing as required. Of course, your ordinance doesn't allow us that flexibility here, but just echoing the request of the team, I think 8 is appropriate. But if you want to take a different approach, we'll certainly work with that. But the next step would be to forward this to HR Finance for its consideration.
Right, and just to supplement, we'd be looking to have these positions hired on through the end of 2024. And so to Lance's point, that we'd really be looking to bring them on strategically, periodically, and ensuring that we have the numbers to continue to support that.
Thank you, Supervisor Crivelli.
Thank you, Madam Chair. With my past support in the, or my past experience in the foster care system, I do know the need, continuously for staffing and the stresses that are put on, the staff that, when you don't have enough. So I'd like to make a motion to move this forward to the Executive Committee.
HR Finance.
HR Finance Committee.
Do we have a second?
Motion by Supervisor Gonring to second the motion.
Thank you, Dennis. All right.
Yes.
Any discussion? Seeing none, all those in favor, say aye. Opposed?
Aye.
Okay, motion carries.
Thank you for your support.
All right, moving on. Number 6B, consideration whether to recommend the provision of continued funding for service contracts with nonprofits, the North Central Community Action Program, and United Way, in connection with the 2024 annual budget process. What are your wishes?
Madam Chair, do you want me to lay
Sure.
any additional context? I apologize. I referenced that I drafted a resolution for this committee. I drafted resolutions for 2 other committees on this stuff, but not yours. So the funding that we're talking about that is historical is the $40,000 that has been historically allocated to United Way 211, and historically allocated to North Central Regional CAP is $33,757. So those are the presentations that were made. Again, the question for this committee, as is for all the other standing committees, is whether you support continuing to utilize the allocation through the budget of those funds, with the understanding that county administration executes a performance service contract with each of those organizations after the budget, or not. I can tell you that the presentation at Public Safety, it was had previously at Public Safety with the Women's Community, North Central CAP, and Judicare Mediation. And there's a resolution in their packet to continue funding at the previous levels. And likewise, with respect to the Extension Education Economic Development Committee, they're going to be evaluating continued funding for McDevco at their upcoming meeting.
Thank you, Lance. Is there a motion?
I'll make a motion to continue the funding for the service contracts for the North Central Community Action Program, United Way 211.
A second? Okay, Donna Krause, second. Is there any discussion? Seeing none, those in favor, say aye. Aye. Opposed? Okay. It passed unanimously. All right, we are down to 8A. Committee members are asked to bring ideas for future discussion. And next meeting is Wednesday, September 6th at 3 o'clock. Do I have a motion for adjournment?
I'll make a motion to adjourn.
Thank you. Second? Donna Krause? All right. All those in favor?
Aye.
Opposed? We stand adjourned. Thank you.